Welcome to Roadmap to Residency. Hello everyone, I'm Aviras. Welcome to our Club 250 Mass Maker sessions. We will be running through a question with you guys to help you on a journey to a 250. In this video, we will be discussing about osteoporosis and fractures. So a 60-year-old postmenopausal woman presents with a history of recurrent fractures, particularly in the spine and hip. Despite minimal trauma, she has also significant family history of fractures. Dual energy X-ray absorptiometry DEXA reveals low bone mineral density at the lumbar spine and hip. Which of the following best describes the pathogenesis of osteoporosis in this patient? Excessive osteoblast activity, decreased osteoclast activity, increased estrogen levels, impaired vitamin D absorption, elevated PTS levels. So decreased osteoclast activity. So osteoporosis is a systemic skeletal disorder characterized by the low bone mass and microarchitectural deterioration of bone tissue, leading to an increased risk of fractures. Postmenopausal women, like the patient in this case, are particularly susceptible to this disease due to estrogen deficiency. The primary pathogenesis of osteoporosis involves an imbalance between the bone resorption, mediated by osteoclast, and bone formation, mediated by osteoblast. In this case, the key factor is decreased osteoclastic activity, leading to inadequate bone resorption and maintenance. So you may be thinking that if there is decreased osteoclastic activity, then obviously the bone is not getting resorbed, and then there should be no osteoporosis. But that is not the case. To make the bone strong, you need constant remodeling of the bone, and for that remodeling, first of all, the osteoclasts will eat out the old bone dead tissue. But due to the defective osteoclast activity, that cannot happen, so inadequate bone resorption and maintenance leads to the osteoporosis. Estrogen deficiency in postmenopausal women contributes to the increased bone resorption by altering the balance between osteoclast and osteoblast. This estrogen normally inhibits the osteoclast activity and promotes the osteoblastic activity. Now, in its absence, there is an uncoupling of bone formation and resorption, favoring bone loss. Ultimately, there is bone loss. Now, reviewing the osteoporosis part from the first study itself. So the trapezoid and cortical bone loss mass despite the normal bone mineralization and lab value. So the serum calcium and phosphate is normal. The most commonly due to the increased bone resorption, increased osteoclast number and activity related to the decreased estrogen levels, old age, and cigarette smoking. Can be secondary to drugs, example steroids, alcohol, anticonvulsants, anticoagulants, and thyroid replacement therapy, or other conditions like hyperparathyroidism, hyperthyroidism, multiple myeloma, and anorexia. It is diagnosed by bone mineral density measurement by DEXA at the lumbar spine, total hip and femoral neck with a t-score of less than equals to minus 2.5, or by a fragility fracture, example fall from a standing height or minimal trauma at hip or vertebra. One-time screening is recommended in females more than 65 years old. Prophylaxis, regular weight-bearing exercise, and adequate calcium vitamin D intake throughout the adulthood. Treatment is bisphosphonates, CRMs, and denosumab, which is a monoclonal antibody against RANKL. So it can lead to vertebral compression, causing vertebral compression fractures, acute back pain, loss of height, kyphosis, and one can also present with fractures of femoral neck and distal radius, called as a Colles fracture. So what we understood is that when the osteoclasts don't get activated, it cannot remodel the bone, and hence we have weak bones. Also, when the osteoclast is overactivated, there's an increased number and activity, then there is increased bone resorption again, and this both pathophysiology can cause osteoporosis. So here you can see there is a kyphosis and a decrease in the height. This is normal bone matrix. This is the osteoporotic matrix, and some of the lab abnormalities in selected bone disorders. So I only want you to focus on osteoporosis, where the serum phosphate and calcium, serum ALP, and PTS all are normal. And these lab findings are very, very important because this will be tested in your USMLE step 1 examination as an up-down arrow. So remember, osteoporosis have everything normal. Normal serum phosphate, normal serum calcium, normal serum alkaline phosphatase, and PTS hormone. Now let's talk about the different fracture types. So fractures are described by integrity of a skin, location, fracture pattern, and displacement. The integrity of the skin or a tissue, soft tissue, it may be divided upon like closed or open fractures. location like epiphyseal, metaphyseal, diphyseal fractures, orientational fracture pattern like transverse fracture, where it is perpendicular to the long axis of the bone, oblique fracture, which suggests a rotational trauma, spiral fracture, which is a complex multi-planar fracture line is present, comminuted fracture, where more than two fracture fragments are present, avulsion fracture, where the fragment of bone due to the tendon, ligament, tear, pull, impacted fracture, where there is an impaction of bone, fissure, where it is parallel to the long axis of the bone, greenistic fracture, incomplete fracture of the cortex, and torus fracture, which is compressive force to more flexible bone. Displacement refers to the distal fragment in or not in anatomical alignment to the proximal fragment. Varus is the apex away from the midline, and valgus is apex towards the midline. The fractures of the fingers and hand, fracture of the distal phalanx that is associated with subungual hematoma, and we treat that with trephination and splinting if there is any underlying fracture. As you can see, these are the different fracture types: transverse, oblique, spiral, comminuted, avulsion fractures, impacted fractures, fissure fractures, and this is the greenistic fractures. Now let's do one more question here. So which of the following is the most likely complication of this fracture? So a 45-year-old male sustains a closed displaced fracture of the left tibia and fibula following a motor vehicle accident. He undergoes open reduction and internal fixation for stabilization. Post-operatively, he complains of increasing pain and numbness in the left foot. On examination, there is swelling and tense compartments of the lower leg. Doppler ultrasound rules out deep venous thrombosis. And which of the following is the most likely complication of this fracture? Fat embolism, compartment syndrome, complex regional pain syndrome, osteomyelitis, or delayed union. So compartment syndrome is a serious complication of fractures and is characterized by increased pressure within a closed fascial space, leading to the decreased tissue perfusion. Symptoms include pain out of proportion to the injury, swelling, and tense compartments. Nerve ischemia may result in numbness and paralysis, and compartment syndrome is a surgical emergency and requires prompt fasciotomy to relieve the pressure. In this case, the patient's post-operative symptoms of increasing pain, numbness, swelling, and tense compartment are indicative of compartment syndrome, likely exacerbated by the surgical intervention. Open reduction and internal fixation can contribute to increased compartment pressure. Early recognition and intervention are crucial to prevent irreversible tissue damage. So this is how the question may be presented to you. So a healthy 25-year-old man is brought to the ED after falling out of a second floor window. He is supported by two friends. All appear to be inebriated with injected conjunctiva. The patient complains that his right thigh is in pain. He reports having landed on his feet. Primary survey is unremarkable. Blood pressure is okay. Pulse is 80. Respiration up to 18. SAT is okay. On physical examination, he cannot passively or actively move his right leg without wincing in pain. AP and lateral radiographs show his right femur reveals an isolated oblique diphyseal fracture. Radiographs of his other femur, knees, and hip are unremarkable. Urine drug skin is positive for marijuana. Pain medications are provided and pose reduction with a splint is applied. The patient is admitted to the orthopedic service. So this is somewhat a clinical presentation of the fracture related questions. Thank you for watching.